Welcome to Managing Fall Risk and Improving Balance with Parkinson's Disease by Eric Horton. Thank you, Eric Horton, for presenting this important webinar. Eric is a physical therapist that has a specialization in Parkinson's. He works for All Star Therapies, providing mobile therapy in the home. He'll share more about that throughout the presentation. Thank you everyone for joining today. And Eric, I'll let you take it away from here.
All right. Thank you, Casey. I appreciate it. Hopefully everybody can hear me. Appreciate the opportunity to take part in this and talk about, obviously I'm a physical therapist, so managing individuals' falls and helping them improve their balance is a huge interest of ours. And we're going to talk about why falls are such a big deal. Like Casey said, this is very informal. If you have questions, feel free to type them in. She'll let me know if we need to, answer that question in the moment. If not, I'll definitely try to leave some time at the end that we can answer anybody and everybody's questions. So the first thing is this is all educational in nature. So please don't interpret any of this information as specific to you as an individual. Everyone has their own medical conditions and the way they present. So a lot of this is general guidance and advice, and then obviously speak with your doctor, speak with a physical therapist specifically about your situation. I don't have any financial disclosures. Now I'm going to show a lot of different specific products today. And we don't get anything from those products. We're not selling these specific products. These are meant to help individuals move better, more independently. And I will say there are some individuals who can benefit from these products and then others who don't. And that's where you want to try specific objects. And so just be aware, I don't get anything from those companies. A little bit about myself. Those are my kids. They have a lot of personality. That was us in Mexico this past April, which was nice. So I graduated from Ohio University, not the Ohio State University. I know there's some confusion with that, in 2016. And I primarily worked with the geriatric population. And I do have a strong interest in the treatment of neurological disorders, specifically Parkinson's disease. That's why we're here today. I have worked in many different settings, including skilled nursing facilities, rehab centers, long-term care centers, and in home health. And then, like Casey said, I now do outpatient therapy, but I'm mobile. So I can come to an individual's home and bring them the needed interventions that they require within the home. I do live in the South Hills of Pittsburgh with my two kids and my wife. And then I am a certified Parkinson's Wellness Power Moves therapist. So that's a specialty treatment for Parkinson's disease. Let's talk about what we're going to focus on today in terms of what I'd like to address is, first of all, I want to make sure we understand the prevalence of falls in individuals who are living with Parkinson's. We need to understand that falls are something that are part of the disease. It's also something that can be part of aging and why it's such a big deal. Then we're going to discuss the consequences of those falls, why those are such a big deal. I do want to touch on the specific symptoms of Parkinson's compared to the general population and what increases the risk of falling. And then obviously, I think what everybody might be looking for is, what is the answer? What are the strategies to help prevent future falls and how to manage them? So the first thing I like to highlight is that we actually live in the Parkinson's disease belt. So this circle of the United States has a much larger incidence of the diagnosis of Parkinson's disease and Parkinsonism than other parts of the country. And there's a couple reasons for that. The first is just age. With increased age does have come the opportunity of certain diagnoses and more diagnoses to come about. At one point, I had heard that Allegheny County specifically has one of the fastest aging populations in the United States. So that is one contribution of why we see an increased diagnosis of Parkinson's. The second is genetics. There are certain subsets of the population that are higher risk of Parkinson's disease. So there is a genetic component to the diagnosis, but then there also is an environmental component. So we have to consider the history of agricultural and industry within the area that we live that may be contributing to an increased diagnosis. So that helps explain to individuals why we see certain elevations of diagnosis in this area. So we're going to talk about the numbers with falls first of all. So these are brochures that come from the CDC. There is a initiative called Steady out of the CDC. It is geared 100% towards preventing falls in elderly individuals and older folks. So the first thing that I want to focus on is falls are going to happen. Falls do happen. I've met many individuals as a physical therapist, and they say, hey, I'm not going to fall. That happens to other folks. Well, 1 in 4 older adults do fall. That's 25% of us. So that they do happen. They do occur. And then they do result in an injury. If we look at the second brochure over there, more than 95% of hip fractures are caused by falls. So they do result in injury. And then the final factor I like to play into and bring about awareness for is that falls are costly to the healthcare system as a whole. You can see the numbers there of how much has been spent from Medicare and from out-of-pocket costs and from other insurance companies to treat falls. If you think about it, if you do incur a fall that unfortunately does result in a hip fracture, you're talking about now hospitalization, a surgery, most likely a rehab stay afterwards, and then you have a home health therapist and then an outpatient therapist coming in and seeing you. Is someone is paying all of those folks. Hopefully you're not. And if we can cut down on those costs, obviously it's less of a burden on the healthcare industry as a whole. Specific to Parkinson's here, one moment here. There we go. Let's talk about the specific numbers for individuals with Parkinson's disease. Is up to 60% of individuals with PD will fall each year. So that's almost 3/4 of the individuals in the population who may incur a fall. And then obviously comparing it to age-matched norms, those individuals with PD are at a 2 times higher risk of having a fall. So these are even heavier numbers that we have to take a look at from a healthcare industry and say, how do we prevent these falls from occurring from the start? And then being aware of recurrent falls are more common in individuals with Parkinson's and Parkinsonism. Sometimes we all fall. You're moving too fast, you slip on something, you turn the foot in the wrong way, you didn't see an obstacle. Those are questions I ask as a physical therapist. What was the incident of the fall? There are many individuals who just were moving too quickly. They made a mistake, they fell. Thank gosh they didn't hurt anything, and it doesn't happen again. So that was just an environmental factor. But we want to cut down on those recurrent falls because then we know there is an issue that is occurring. Let's talk about the consequences of falling. I think it goes unsaid that, major physical injury is probably the first thing that most individuals think of after a fall. And yes, that is a big issue. We do not want individuals incurring a broken hip or a broken spine or anything like that. But I want to focus and bring awareness to the next 2 factors on that slide. The first is a decline in confidence. If you incur a fall, you are and understandably going to be hesitant with your almost immediate mobility and your confidence with mobility with certain tasks as you move forward. So we don't want that decline in confidence because it has been studied that a fear of falling can cause falls. So if you think about that for a minute, being lacking confidence with certain mobility or fearing falling, being hesitant with movement and mobility can actually lead to further falls. So that's something that we want to bring awareness of and prevent if we can. And then the second factor is having a fall is an added stressor to the body. Okay. Now, I'm not saying this occurs in every situation, but I have seen this anecdotally myself, is that it is possible that stressor of a fall could be a pro-degenerative event where it progresses the disease in some way. And then, we see more symptoms after that fall. So these are the consequences of falls. And I know it's been very negative up to now, but falls can be prevented. And we're going to focus on the positives of helping give interventions and awareness to the prevention of falls. So let's talk, first of all, and many of us are aware of the Parkinson's symptoms, but I'm going to highlight on the ones that increase that risk of fall that makes us 2 times more likely of falling than our age-matched normal partners in the community. So the first is instability. There are balance changes that can come with the disease that cause instability. And secondary to that is a change in kinesthetic sense. And that's just a change in understanding where the body is in space, knowing where our center of mass is, where our base of support is. Those are changes that can occur and affect our risk of falling. The second is the gait changes. Obviously, most individuals know this, that we're dealing with the shuffling gait, the short stride length. We may catch our toe on a throw rug, and that increases our fall risk. Freezing. Freezing is, the number one thing that I try to combat as hard as I can. I have clients right now that we're trying to tackle the freezing as hard as we can, and it is very difficult to treat. Freezing is that instance where the foot just gets stuck on the ground or it's glued to the floor and we can't progress any further forward. And that can lead to the festination. And festination is that fancy term where there's the short shuffling steps and then the center of mass is just going forward and then we can fall forward. And then having a slowed gait speed. A slower gait speed or slower walking speed actually can increase our fall risk. In addition to that, the muscle weakness and the motor coordination, incoordination that can come with the Parkinson's disease increases our risk of falling. Let's talk about non-motor symptoms. Sometimes these can be overlooked, and people are unaware of these conditions. And these are what I love to do is coming into a new client and yes, physical therapy. I'm a physical therapist. Most people think I'm going to look at your muscle strength and your balance and your mobility. I am. But half of my first session with my clients is advocacy and understanding the other symptoms that they're dealing with. Interviewing, let's take a look at everything that you're dealing with. Do you have visual changes? Do you have blurry and double vision? We rely heavily on our vision to keep our balance. That's why everyone tells you to have night lights on at night when you have to get up and go to the bathroom, put the night lights on. Okay. So if you have visual changes, you may not think that's affecting your balance, but I guarantee it is. Now, I'm not going to address that as a therapist, but if we can bring awareness to that, you need to go see an optometrist or an ophthalmologist to help handle those issues for you. Blood pressure. Many of us will stand up and too quickly and we get lightheaded. In addition to that, when you have a neurological disorder, you're at a high risk of a change in the autonomic system, the nervous system, where you can have neurogenic orthostatic hypotension. And we're going to talk about that. That's when your blood pressure drops and it causes that lightheadedness. That can lead to falls. And then cognitive impairment. This is very difficult, obviously, for caregivers and spouses to address, but we have to be honest with the safety awareness that the individuals with Parkinson's have. And if they're, lacking some safety awareness because of a mild cognitive impairment, how do we address that? And then we, definitely looking at the medication side effects and that fear of falling. Moving forward here. There we go. So fall prevention is multidisciplinary. It's not handled by your physical therapist only. It's not handled by your neurologist only. If we can raise awareness for all these factors and assess what's causing the falls, we can help address them the best way. So we need to rely on the specialist. Is it an ophthalmologist? Is it a psychiatrist who can help us address the depression and the apathy and the lack of affect that can come with the disease? The rehab team obviously has a humongous input for that. Speech therapist not only are going to help with the swallowing, but can help with cognitive impairment and cognitive strategies. Occupational therapists can do an entire home assessment and give you tips and tricks of different devices to help improve your independence. And then even a registered dietitian. Think about your diet. There's no specific diet for Parkinson's for the disease itself, but there are different diet recommendations that can be made for the symptoms and the management of it. So where do we start? I love this graphic from Steady is that it breaks it down. And then I'm going to move on to the next slide and it's going to look way too busy, but we're going to screen. Let's identify those risk factors that you have specific about your falls. We're going to assess those risk factors. And then what can we modify now? Most likely you're not incurring a fall or having a fall from one single instance. There are many factors that are playing a role, and there are probably some of those that you can prevent now or affect now. And then can we intervene with a specialist? So don't get bogged down in this slide at all, but this is a basic algorithm that the steady initiative has given us. And it really goes step by step. And this is a pocket guide so people can print it out and fold it up. It's really kind of meant for healthcare providers, but we start by screening, and I'm going to bring up just a laser pointer here, but we start by screening. So there's some simple questions that we can ask, and I want you to ask yourself right now is that, do you feel unsteady when you're standing or walking? Do you worry about falling, or have you fallen in the past year? If you answer yes to any of those questions, you need to be screened further for risk factors. Okay. And it doesn't mean you have to go to all those specialists to start. Start with one person, start with an entryway into the health system or into the healthcare system. If you don't know where to start, call me. Okay. Email Casey or email me. We'll have a conversation and let's see where we can help you. Okay. The second box here really tells you everything that you can do right now to modify. Okay, the first is we can look at your balance, your strength, and your gait. And that really comes down to a physical therapist or a neurologist doing those assessments on you. But medications, if you are on 5 or more medications, you automatically are at a higher risk of falling. Now, I'm not advocating for less medications, and you may need all those medications, but when is the last time you've spoken with your doctor about all the medications you're taking? That's a good question for your next checkup, is say, hey, let's just do a quick medication review, make sure these are all still appropriate for me. Hazards in the home, throw rugs. Yes, I have many clients who have beautiful throw rugs from other countries that they've had for 40 years in their house. That's fine, and I'm not saying you got to get rid of them. You got to figure out a way to tape them down or get them secured down if you start tripping on them. If you're shuffling and that throw rug's picking them up or the walker's picking it up, let's take that throw rug and let's hang it up on the wall. That way you can still enjoy it, but you're not getting stuck on it on the ground. Okay, so just consider those basic changes that you can make now, whether it's for yourself or whether for you're a spouse or a caregiver to help somebody out. Measuring your blood pressure. So many folks can do this on their own, and then I even do this as a therapist. We're going to talk about that. If you're noticing changes in your eyesight, go get an eye assessment, please. Talk with your doctor. And then there's many other interventions that we're going to talk about moving forward that we can discuss about falls. Okay. So there is a basic clinical prediction tool that us therapists or other healthcare providers can use that really predicts with high accuracy falls in the future. Okay, there's 3 rules to live by. If someone has had a previous fall in the last 12 months, if they have freezing of their gait, or if their gait speed, that's just how fast you're walking, and there are ways that we can measure this. It's slower than 1.1. That tells us that you're at a much higher risk of falling. And it does tell us, listen, we need to intervene with this quickly. We don't want someone incurring a fall and resulting in an injury. So knowledge is power. This is something I tell all my clients is the more information you have about understanding Parkinson's and everything that does come with it, the better control you can try to take of the disease and try to manage the best you can. Okay, so I advocate for as much knowledge as you can, and that's why you're on this webinar right now. So talk with a medical provider. It doesn't have to be your doctor, your neurologist. I would start with them, but like I said, you can call me, call your therapist, call your dietitian, whoever it is. Increase your knowledge of Parkinson's. Request a medication review, like I said, and then keeping a symptom diary. And there are many different symptom diaries that you can keep. First of all, if you're falling a lot, we want the details of those falls. So write down the date, write down the time, write down when the last time you took your medication was, and we can figure out what's causing these falls. Why are we falling so much? Individuals with blood pressure issues, write them down. Take your blood pressure in the morning, take your blood pressure in the afternoon. Let's take a look if we see some patterns in what's going on with your blood pressure. And then with your symptoms as well. There are different symptom diaries out there that you can print off, and then you can just keep track of your symptoms. Okay. Exercise, exercise, exercise. We've all heard that before, and that's what I'm going to kind of move into now and talk about. So how does exercise affect Parkinson's? many different ways. There's physiological changes, including increased blood flow to the brain. That brings neurotrophic factors and healing factors. It improves our immunity. It can promote neuroplasticity, and that's basically a fancy term for saying different parts of the brain are moldable or plastic, and they can learn different skills. Now, that can take thousands and thousands of repetitions, but the more we practice, the better. And it can decrease our motor and our non-motor symptoms. And then obviously a lot of exciting research coming out saying that exercise may have a neuroprotective effect. So can it possibly slow down the progression of the disease itself? Okay. So I'm gonna move into some of the specific symptoms that we talked about and what is causing falls, and then how do we manage it or how do we intervene? Okay. So we just heard that 61% of individuals with Parkinson's fall because of freezing of gait. Okay. Now this is not my quote here, but I think it's the best way to say it. It's done by the folks who did the research study down below here, Nutt and other individuals. But it's a brief episodic absence or a marked reduction of the forward progression of the feet. Okay. Are your feet getting glued to the ground? Does it feel like you have cement blocks on your feet? Now, there are many different forms of freezing. There can be a start freezing where an individual is just starting to walk and that foot won't move and they're kind of, ratcheting back and forth trying to get that leg to go. There's freezing that occurs with turning. So there are many different of freezing. And then, like I said, one study had shown that 61% of individuals fall with Parkinson's because of freezing. There's a great way to measure your freezing. It's called the New Freezing of Gait Questionnaire. It's a subjective questionnaire. I bring it day one to individuals, and they can fill it out. And it's a good way to kind of measure and then track your progression of freezing as well. Okay. So how do we address freezing? Freezing is very tough to address. And if you're one of my clients or been a past client, I sometimes feel like we're taking one step forward and two steps backwards with freezing, but we're doing our best to combat this very difficult effect on the way we walk. There are two routes that we really look at. The first is a neuro-recovery route, and this is basically training the way we want to walk or normalize their movement. Okay, so we want to normalize the walking pattern to the way it was before. And there's many ways to do that. It's through dual task training, or what they call set switching, where, okay, you're telling me you freeze when you turn to go into the bathroom, or you freeze in the kitchen, right? You got something cooking on the stove and you got to go turn the timer off or go to the fridge. We're going to practice in those settings in a controlled environment to start, and then we're going to bring it to the large environment where we're doing more than one task at a time, whether it's physical, or cognitive physical. That can be carrying a tray of water and trying not to spill it and walking, or carrying on a conversation, or naming capitals, or different cognitive tasks that you can do while you're walking. Balance training, lunging, multi-directional movements, obstacle courses are all great interventions for freezing. And then treadmill training. And we take both routes, but if neuro-recovery or training the walking the way we want it to be and the way it was before is not working because of the progression of the disease, we're also going to look at compensatory strategies. Compensatory strategies are training the movement with devices, okay? Whether it's a metronome through auditory cueing, or clapping or counting. That is a way to compensate for a lack of automaticity in the walking. Visual cueing, they've talked about individuals putting tape on the floor to take bigger strides towards. Now, here's what I'll say is I think it's a great idea, and there are folks who have done that, but your whole floor could be covered in tape in your house too, and that's not necessarily feasible. You bring folks over and you're hosting and you're like, well, what the heck is all over the floor here? So there are also laser devices that I want to introduce you to and show you. Visual imagery. I think this is a huge benefit to, before you get up and walk. Let's say you're sitting on the couch and you need to, go to the kitchen and get a glass of water. Visualize in your head before you even move how you're going to get there. And then this isn't my quote either. This is from Maria Allen, who's a physical therapist and with the Power Gym, is do destination guesstimation. So if you're noticing that you're shuffling and freezing, is I'm going to go to the kitchen and I think it's going to take me 20 steps instead of 40 steps, and try to guess how many steps it'll take you, and then focus on taking those large steps, and visualizing the movement can really help. And then there are specialty devices. So when I was preparing for this, and then even as I prepare to help my individual clients, is I ran across this study, and I thought it was really interesting because many individuals that I'm aware of, especially who are very active in the Parkinson's community, are active in group exercise classes. Okay. So this is a research study, and this looks kind of complicated, but I'm going to start off to the left here. Is that they took a group of individuals with Parkinson's. Okay. And I think there were 46 folks in this test, and they did a baseline assessment on them. So they actually did imaging of their brain, which is very interesting because that can be invasive, right? And it's hard to do imaging of the brain versus just testing someone's strength. They did a cognitive test, and then they did mobility tests. And then they broke that group up into two groups. The first went to ABC-C. That's a fancy term for group exercise, okay? Or the second group went to education. And then they remeasured them after 6 weeks. So the group that did the agility boot camp, ABC, it was a cognitive agility boot camp. It was 80 minutes of exercise 3 times a week for 6 weeks. And the exercises weren't all the same. They did gait training, walking training. They did functional training like sit to stand transfers or getting on and off the floor. They did obstacle negotiation, boxing, lunging, tai chi. There's nothing fancy in there, right? They just did these different stations, 80 minutes, 3 times a week for 6 weeks. The education group did a Parkinson's wellness focus for 80 minutes. It was a lot of education on Parkinson's. So these groups split up. They did 6 weeks of the intervention. They remeasured all the same things they measured at baseline. And then they actually switched groups, which is interesting. So they switched to the different intervention and then remeasured. But we don't need to get bogged down in the research. But what I like to bring up the research, and sometimes it gets very boring. And even when I listen to folks about research, my eyes glaze over, and I tone it out. But everything we do from a medical and a healthcare standpoint needs to be based in research. I'm not saying it is based in research, but we need to focus on the research because we know that's what helps individuals. Okay, so here are the results of this group exercise. There were improvements in the subjective freezing of gait. So they interviewed the clients and they asked you, has your freezing gotten better? And the clients said yes. The participants said yes from the exercise. Okay. Now, here's why I don't want to get too negative, but they did not see any objective changes in freezing of gait. So when the clinicians measured freezing, there was no change after the exercise group. Okay. Now, don't go too bogged down in that because they saw huge improvements in balance. Okay. They saw improvements in dual tasking or doing two things at once. And they saw improved brain connectivity. I said they measured the brain through MRI. So there were actually changes in the brain. So listen, even though I bring up this because it's hard to combat freezing, but there are huge improvements with group exercise classes as well. Okay. Through lunging, boxing, tai chi. Okay. So I talked about the neuro-recovery route in a research study. Let's talk about compensatory. So there are two main forms of compensatory training. The one is aural cueing or auditory cueing, and a lot of people think of a metronome with that, okay? And the second is visual cueing and using a laser or a visual target, all right? And I want to talk about both of those in some of the research, and then I'm going to show you a video on a couple videos on use of those devices, okay? So auditory cueing, it can be a metronome, it can be music, okay? It can be a beat, whether it's just clapping, your caregiver clapping and helping you walk to the clap, okay? A lot of people ask me, they go, what speed do I use? When I set the metronome, what speed do I use? And I want to highlight, you want to use a comfortable speed that is your self-selected walking speed. Start with that, okay? So I have a metronome on my phone, and you can actually push a button and tap every time the person walks. So that allows me to set the speed. And then I just look at the number and I'll play the metronome out loud, okay? But then if you want to push the speed a little bit, go up to 10% higher. Okay, so take 10% of that number and add it to the metronome, and then you walk to that beat. So they did a study on that, and 10% higher gait speed on a metronome did increase someone's stride length, their gait speed, their walking speed. And it lasted up to 3 weeks after the intervention was taken away. Okay, now after 3 weeks, they didn't see those effects. So that indicates that this is difficult to treat, and that when you start using a metronome or a beat to walk, you may always need it. Okay, which is tough. Let's look at one more research study. There was 130 individuals with Parkinson's, okay? And they measured their gait with dual tasking scenarios. So I put it right here what they did. They stood up, they walked to a chair, they picked up a tray with water cups on it, and then they had to walk back to the place they started. That's what they had to do, and they measured that in different ways, okay? And then they gave the individuals a cue. So they gave some individuals an audio cue through a metronome. They gave some individuals a visual cue through targets or a laser line on the ground. They gave some individuals a sensory cue. This is kind of neat. They put a wrist cuff on, and the wrist cuff would tap or vibrate their body to walk to. And then they just gave no one a cue. They took a cue away. And what they showed through this research study is that there is a huge benefit to performing a dual task scenario through external cues. So the cues help. Utilizing those cues helps, and it lasts up to 3 weeks. It doesn't last any longer than 3 weeks, but it can last up to 3 weeks. And then it's interesting, they found bigger improvements with an auditory cue compared to a visual or sensory cue. Okay. So let's not get bogged down in the research, but these things do help. And I want to show the base of why we're talking about this. So I'm gonna take myself out of this slideshow view. Hopefully you guys can still see my screen. Let me check here. Good. Okay. And let's watch a couple videos. Okay. Now none of these are well, I'll tell you which ones are my videos. One moment here. Okay. So this is an example of a laser cue device. Okay, so I'm going to skip ahead.
Imagine not being able to walk. The condition causes his muscle
Line is your target.
is giving Wayne his mobility back.
See, this is more like what walking's supposed to be like.
This simple device, a laser attached to a walker, is called the mobile laser.
Mobile laser is a device.
So I'm going to show that one more time just so
His
you can
mobility
see that
back.
red
See, this is
line.
more like what walking's supposed to be like.
This simple device, a laser attached to a walker, is called the mobile laser.
Mobile laser
Okay.
is a device.
And I don't want to get bogged down into the oh, one moment here. I'm sorry. I stopped screen sharing somehow. Let me get that back to screen share. Can you see that now?
We can see the video now.
Okay, there we go. Okay, so this is that is a laser line that is a visual target for an individual who is shuffling or freezing to reach their foot out to. Okay, excellent. So the next thing is, and this is not, this is the best way for me to introduce this walker to you. I'm going to show you the U-step walker. Okay. Hey guys, Eric Horton here, physical therapist with All Star Therapies. Wanted to demonstrate the U-step neuro walker. This is a sample walker that we have to use with folks who are at risk of falling or have Parkinson's disease or some other movement disorder syndrome. You can see it is normal. It's like a normal rollator, however, it does have a U-shaped base on it. So it has a better turn radius and it's a little bit more stable than a normal rollator walker. What I'm really excited about is it does come with what they call the cue. You can see it has a laser on the back here. In addition, it does have a metronome as well. These external cues are meant to help an individual take bigger steps and reach their feet out there to combat shuffling, freezing, and festination. Okay, so that is the U-step walker, and it's kind of an all-in-one type walker that includes the cue, and it has both a visual cue through the laser that you can see there, and then also a metronome that is an audio cue. You can use them both at the same time, or you can use one and then the other. Hey guys, Eric Horton here. So let me try to get past. The next thing that I want to introduce is obviously that was a walker. Maybe some people don't need a walker. Okay, maybe you don't need the support of a walker and you just want to still have a mobile visual cue that can be attached to any type of device. And that's where the next stride is a laser device. And it was on the previous page, but this is actually an individual who uses their visual laser cue on their treadmill for exercise, not just for general mobility, but to help with fitness training and for exercise. So the general idea is, there's no sound with this video, but the general idea is that this cue is that we don't have the internal mechanisms to take a bigger step, so we use an external visual cue to reach the foot out there and tap onto the laser or step past the laser. And this is a great way to focus not only on, you can see how the individual now is taking a step onto the laser there and reaching the larger stride out there. Okay. So these are a lot of compensatory strategies. I'm going to move on to the next slide because we get bogged down in the videos here. These are great compensatory strategies and devices to help combat shuffling or freezing and decrease fall risk. Okay, now here's what I'll say is that, first of all, I don't get anything from these devices. These are to help an individual move more independently. We have these sample devices. I would say most specialists should have the device. I know the foundation has a next stride device that if you think it's beneficial, trial it. I would use a device under medical supervision. Don't just try to take one off the street and try it. Is go through some training with it, okay? There are benefits and consequences of these devices, okay? The first thing is with the laser, we're looking at the floor, okay? And I always tell my clients, there's no money on the ground, get your head up, all right? But the problem is with the laser, you have to look at the laser to use the laser. It's only going to help you if you look at it on the ground, okay? Whereas the auditory cueing is, you can hear it. Your head can be anywhere and you can hear it. Though the auditory cueing, let's say you really benefit from a beat, step, 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 step. You want to go to the grocery store. Now, I hope you're comfortable in it, but you're not playing that metronome out loud when you go through the grocery store, right? So there are benefits of both devices. So try them. If you have questions about them, if you think, hey, this might be something I'm interested in, what I'll say is that the U-Step walker is covered by Medicare. It's one of the only specialty walkers that is covered by an insurance. And sometimes cost of these devices is a huge factor. I understand that. So we try to find ways around it. There are foundations out there that have scholarships for certain devices and different grants to help you obtain them. Okay. The last thing I want to show a video of is trekking poles or Nordic walking poles. Now, these are actually the poles that we have that we try with our individuals. So let me just show you a brief video on the trekking poles. And I'm going to turn the volume down, but they're going to show you different, a side-by-side view here of an individual with Parkinson's on how they're walking with and without the activator poles. Okay, and you can see a big difference. Now, she's pretty steady on the grass. It's not like she's falling over, but those activator poles are improving her stride length, her reciprocal stepping, and her upright posture. Okay. So these are another way to get a point of balance or get stability, at decreased risk of falling, and also increase our symptoms through a device. Okay. Over here off to the side now is it does provide a point of balance. It's like a cane, right? But it doesn't look like a cane. It looks like, first of all, everyone jokes around when I have someone on, they're like, we're going skiing today, aren't we? So, it provides a cue to swing the arms. So here's what I'll tell you. When I give someone Nordic walking or trekking poles, I just tell them just walk. Just start walking. Because if I tell you how to use them, we get bogged down in the details and then it tends to fall apart. But anecdotally, every single person, not every single person, but most people, I put this in their hands, they automatically subsequently improve their walking stride length, which is fantastic. It almost automatically does that. Here's what I love about these poles is they don't look like a walker or a cane. I work with many individuals who don't want to use a walker because they don't want to be seen on a walker. I understand that. That's a huge barrier. Okay, Parkinson's is a very isolating disease. We want to get you out. I don't want to give you more devices where you're like, I'm not going out with this thing. But maybe you'll be open to going out with trekking poles that can help improve your balance. And there's evidence for this. This is an amazing study, is that they gave individuals a 12-minute walking sessions with these poles, not lots of hours, not lots of practice. They gave them like 3 1-hour sessions, and it automatically improved their stride length. So almost immediately, these poles can help certain individuals if they're appropriate for it. Okay, so moving on, I know, I knew I would go over on time here. I'm going to go through some other factors very quickly. Orthostatic hypotension. If you get dizzy or lightheaded when you stand up too quickly, or when you change positions, it can be laying to sitting or sitting to standing, you need to talk to somebody about it. You need to measure your blood pressure. Okay. We do not want you falling over because you stand up and you get lightheaded, you pass out and you fall. All right. I measure orthostatic hypotension levels. I talk with your doctor, communicate with them, give them the numbers, and then they can adjust things from there. Okay. Now, there's a couple things you can do right now to help with this. The first thing is if you drink a cold glass of water, almost immediately your blood pressure will rise a little bit and your symptoms will go down. Okay. If you pump your ankles or squeeze your legs before you stand up, that helps raise your blood pressure. It'll decrease some of the symptoms. Okay. And then if it's really, really bad, and I've dealt with some clients where it's so bad they can't function, there are medications you can take to help raise your blood pressure. All right. This is a podcast down here from the Davis Finney Foundation. Fantastic podcast on neurogenic orthostatic hypotension. If you're dealing with these symptoms, please listen to it, or have a caregiver listen to this podcast. Okay. Keep in mind, one thing I learned through this podcast, I always thought, hey, the symptoms occur right when you stand up, right? No, they can occur up to 20 minutes after you stand up. So I've had some folks who stand up, they're fine. They start walking and then they get dizzy or lightheaded 10 minutes later. And I'm like, it can't be your blood pressure. It can be. Okay. So keep that in mind, that can be a huge factor. Medications. I just had a conversation this morning about medications and kind of mobility. There's no specific medication that can decrease your fall risk directly. Okay. Medications are very important for impacting the symptoms. And that's how medications, if medications are controlling your symptoms, they can decrease your fall risk. But I looked through some studies. There's not just one study that shows this medication directly decreases fall risk. It can indirectly keep it, but if you're worried about your medications, any side effects you're having or anything, talk with your doctor, keep a diary. Okay. Exercise. So they have done a lot of multi-analysis and analysis of different studies on exercise. Exercise can reduce falls by up to 35% in individuals with Parkinson's. Okay. What I want to point out is that supervised or guided exercise was better than independent exercise, which is interesting because as a therapist, my goal is to put exercise in people's hands and have them do it on their own. The insurance doesn't just keep paying for me to come in and give people a kick in the pants. I need them to be independent with it. But this points out that we need to rely on our caregivers or our spouses or our whoever's watching us to supervise us with proper exercise. And then there was no one mode or type of exercise better than the other. We need to be doing different types of exercise. Okay. And it needs to be cognitively and physically challenging. So let's talk really quick about the exercise recommendations for Parkinson's. Okay. Aerobic exercise, getting your heart rate up, getting your breath rate up. You need to be doing 5 times a week at least for 30 minutes, and it needs to be intense. On this scale over here, this is the RPE scale. It's a really good way to gauge intensity. You should be working, depending on your health status, moderate to vigorous. Okay. For folks who are very fit, maybe even very hard on this scale. It needs to be intense. I have a lot of folks who say, hey, I go for a walk around the block. It's a mile. It takes me an hour. And the next question I ask them is, are you breathing heavily after you go for that walk? And they go, no, we sit there and have a conversation the whole time. That's great, but that is not counting as your cardiovascular aerobic exercise. Okay, we got to find another way. Stretching, break up that rigidity. Okay, we got to stretch. Strengthening. I have a lot of folks who want to do resistance training, and there's a great place for resistance training in the management of Parkinson's, and then obviously balance training as well. Okay. we're gonna skip over this video, but the one thing I want to note that is overlooked is I get my clients on the floor as long as they're safe. Okay. And I'll help you get back up too. I'm not going to leave you there, but you should practice getting on and off the floor. There's a huge benefit of getting on the floor and doing exercises on the floor. So the Parkinson's Wellness Recovery, the power certification I have actually has exercises you can do on the ground. And I love it. And we can practice getting up from a fall because a fall may happen, and we don't want you to be unprepared to try to recover from that fall too. So make sure you do address that. Get comfortable getting on the floor with your therapist or with your caregiver. And then do what you love. The number one thing with exercise is I just made those recommendations, but if you hate jogging or rowing, don't do it. There's other ways to get cardiovascular exercise. Rock steady. Boxing. A lot of people like that boxing. We get some aggression out, right? So, you get to get the cardio in, get the aggression out, get the balance out. Pickleball, silver sneakers classes. And then I am going to put a shameless plug in here for if you've ever seen cardio drumming. Okay, do something you love. Now, I don't know if you like Justin Timberlake, but we have Taylor Swift songs as well. Okay. But anyways, do something you like to do. Find an exercise you like to do. All right. The Power Moves group exercise classes, LSVT Big, the Rock Steady Boxing, Tai Chi. There's a ton of evidence for balance improvements with Tai Chi. And then obviously utilize the foundation and their online classes. Like the majority of the classes that are listed here are free to attend and they're online. Okay. So utilize those resources to help manage your symptoms. I said knowledge is power. There are a ton of podcasts out there where, to be honest, I know I have a ton of experience with Parkinson's, but I still learn things every day. And there's new stuff coming out every day for the management of it. Is that if you're interested in learning more, stay up to date on it. Subscribe to these podcasts. They're free and they bring new evidence out all the time. Okay. This app here in the middle, this is actually an app that helps you track your symptoms. Okay. And I have to acknowledge a client put me onto this app. I didn't know about it. But if you want a technological way to track your symptoms and write down how to talk with your doctor, download that app. Check it out. Okay. There's good things about it and bad things about it. And then this book, I learned about this book from a podcast. It's an awesome, great resource. It kind of looks like a workbook though. It's not like a read for pleasure book, but if you want to learn about different forms of exercise and how to manage it. And then what I love about this book is they bring in anecdotal stories from individuals who are living with Parkinson's who do that type of exercise. Check that book out. Okay. It's a great resource that you can take a look at and gain some motivation from. So a lot of information. I probably talked way too fast, but take a deep breath. Okay. Start with one thing. If you're worried about falling or have had a fall, you need to start with a conversation with a medical provider. Call me, call Casey, call your neurologist. Okay. Go through a physical therapy or specialist assessment. If it's vision, you call me and say, I have blurry vision. What should I do, Eric? I'm not coming in here and billing your insurance to help with the vision. That's not me. We got to go to an optometrist. Okay. Identify what's causing it. And then that's where we implement strategies. So I have folks who say, hey, I want to know what you're going to do with me before we start. And I can't tell you. Everyone's different. I need to know your specific situation. Thank you guys so much. I appreciate it. If you do have questions, ask away. I know I saw some stuff in the chat there. Casey, come along.
Thank you, Eric. I'll
You're
read
welcome.
the first question. Is kinesthetic sense the same as having spatial issues, misjudging things?
Yes. Yeah, not to not get bogged down in the different forms of proprioception and knowing where the body is in space. So there can be kinesthetic changes with understanding where our body is from a balance standpoint in the center of mass, but then also visual spatial issues. So understanding depth perception issues or misjudging movements. Yes. So there are a lot of different causes for that. That's where a specific assessment is indicated.
Thank you. Another question. a friend was having pain with gait problems too. They found out in the aging process, one leg had become shorter than the other, and using a lift in a shoe helped.
Mhm.
Is leg length something that is routinely checked?
That's a great question. So this brings up a good point, right? We're talking about Parkinson's today, but most individuals are not just living with Parkinson's. They're living with different diagnoses, including orthopedic conditions. So yes, we can do a postural assessment. If there's a leg length discrepancy, putting a lift into the shoe and equalizing the bony landmarks can be a huge benefit. Yes. So yes, it should be assessed. Would I say when I first go into a client, that's the first thing I look at? No. But this is something where having a specialist provider constantly assessing you is important, right? So I'm always assessing my clients, even though I've seen the clients for 6 months in a row. We are constantly assessing them and changing how we approach their exercise of their therapy. We're figuring out what's working, what isn't working. Oh, I didn't see that day one. I'll be the first to admit it, but let's address it now. Yeah.
Thank you. Another question. Do you have any thoughts on the Perfect Walker 2 upright walker?
I would have to look it up. It's called, well, and that's what, listen, I brought a notepad because I'm writing down questions and things that I need to take a look at as well. So what was that called again? The Perfect Walker 2?
Yes.
Okay. I will say there's only so many different types of walkers that can be out there, but you said the word upright walker. So there are upright walkers that have forearm supports that can help an individual stand up taller with better posture. And those have been a benefit to individuals in the past who have more of a stoop posture or postural changes. They make the U-step walker in a forearm walker as well. But I will look that up.
Thank you. Please, if you have a question, type it in the chat, or you can raise your hand and unmute yourself and ask it. And while we're waiting for more questions, I have a question, Eric.
Yes.
Thank you. What if your insurance company has shared with you that there are not any additional sessions that have been
approved.
approved? Thank you.
The insurance, first of all, I'm not an insurance expert, okay? And you should always meet with someone you trust and an advocate who knows all the different plans out there, okay? I see the insurance benefits from the lens of the therapy side of things, and that's, I hate to make recommendations based on that, is maybe some people don't utilize a lot of therapy, but they utilize the hospital a lot, and you have to look at those benefits. But that's where you need an advocate in your corner, and also an individual who has some different routes that they can take from a therapeutic standpoint. Okay. So first of all, yes, eventually the insurance does end. There are some indications where with Medicare, we can provide what's called maintenance therapy, and we have done that before. So maintenance therapy is not necessarily focused on getting someone better all the time, but preventing a decline. And that is covered by Medicare, straight Medicare. A lot of Advantage plans don't cover that. Okay, but it's something to ask about and inquire about if that's important to you. My number one goal for my clients is to somehow get exercise into their hands day one. Okay. I come up to my clients about twice a week. You still need more exercise than that. We just said you need to be exercising 5 days a week cardiovascular. Okay. So how do we break down those barriers? Is it your caregiver? I've spent 30 minutes with clients showing them how to log on to the Parkinson's Foundation Western PA website and how to sign up for an online exercise class, right? People don't know how to do that. So let's show them how to do that. Let's give them the resources to exercise on their own. Is it a group exercise class in the community? So that's the first thing, is that, we need exercise outside the insurance benefits. You have routes you can take. If your insurance says, hey, we gave you 38 visits and you're done, no more, you can't appeal it. That's where having a strong advocate in your corner can help you appeal that process. Have a therapist who can fight for you as well. I've done peer-to-peer or done a conversation with insurance companies before to help, get more visits and advocate for individuals as well. Or keep in mind, therapy with Parkinson's is episodic. Okay, so okay, we did 12 visits with you. We made some progress. You're not where you want to be, but let's give you an exercise routine you do on your own and then call me in 6 months or call me in 4 months and we'll pick back up from there. I see my clients on and off quite a bit.
Thank you, Eric.
Question. Yes.
It's always important to have that advocate.
It is. Yeah, it is.
Any last questions? That was very thorough, Eric, and I think all of us were given some tips that we can take with us. Eric is available. If you would like his contact information, just email me. I will share that with you.
Yeah, that might be the easiest way. I apologize. I didn't put my email on the last page here. I can put it in the chat right now if someone does.
Okay. Eric will put it in the chat. And if you don't capture that, just send me an email. I'll be glad to connect you with him.
Casey,
Yes.
can you hear me? Casey,
Yes.
Judy Belanti here.
Hi.
Hi, I'm sorry, I can't figure out how to use the chat thing. I've been sitting here for 5 minutes trying to put my question on chat and I can't get it on.
That's okay.
But
Go ahead and ask it. I think we have another. Do you have another moment?
Oh yeah,
Yes.
Ask away,
Go
Judy.
ahead, Judy.
You're good.
Okay, I just wanted to know, when you referenced the Parkinson's belt, where can I find more information on that? Where did you find your information?
So I mean, a lot of that base information that I cited there was actually from my education in physical therapy school.
Oh,
On that slide, and I can go back to that slide. I actually reference an article from Senior Blue Book that talks about the Parkinson's belt, and they talk more specifically, there it is, about the causes of it. Okay.
I see.
And what is caught? Why do we see more Parkinson's in the northeastern part of the United States versus the western? Okay.
Thank you.
Yeah.
And this is the website, seniorsbluebook.com.
Yeah, that is the article that I have cited that information from. But if you Google Parkinson's disease belt or epidemiology, it's all based on diagnostic numbers.
Thank you. Thank you
You're
very
welcome.
much.
Yep, good question. I see a couple. Now I have the chat pulled up too, Casey. Is Phyllis
Okay.
asked if I do travel beyond the South Hills. Yes. I mean, I'd love to stay close to home, but that's not happening. So which is great. Yeah. So what I would say is reach out, email me, talk with Casey, get my contact information. We can talk about your specific region. I will say I don't cover everywhere, but we have a team of therapists that do work with us. And then if we can't get you the help that you need, I try not to just say, hey, I can't see you. Let's find someone who can. Okay, let's find you a specialist if someone's in your area. Karen, great question. I'm not going to get into the geographical history of industrialization. I don't know that answer. I appreciate history, but I don't know the specifics of that. That's just part of it is like the heavy, if you think about the steel industry in the Pittsburgh area and sort of the heavy metals. But yes, there are many other industries in other parts of the country. I can't explain, the actual factors that play into that directly.
More to come on that for sure.
Yes. Yeah. We need like an epidemiologist to describe the historical factors and advancements and how it affects disease for that. Exercising, physical therapies, massage ideally. Yeah, definitely massage. So Sydney's talking about contacting about massage and exercise. And there is a huge benefit of relaxation techniques. And that's the umbrella term I'm going to use for that. Is I talk about, the drumming is high intense and running is high intense, but we also need the opposite of those fight and flight and high energy situations. Okay. So we know that there is anxiety and depression that can come with Parkinson's as well. And having relaxation techniques can help manage those symptoms. Okay. So I've had clients who get very anxious in certain situations, and that can be a huge cause of more symptoms of Parkinson's and cause them to freeze or shuffle. So focusing on meditation and yoga, and then even having massage, even for the management of pain, can be helpful. So yeah, please reach out. I'd love to talk.
Hey, I think that's it. Thank you for joining, everyone. We hope to see you at Step Forward on September 28th. And if you'd like more information regarding Eric, just send me an email.
Sounds good.
And thank you, Eric, very,
You're
very
very
much.
welcome. Thank you guys. Have a good day. Enjoy this weather.
Yes. Bye, everyone.